Welcome back to the deep dive. Today, we are plunging into, well, one of the most high-stakes balancing acts in the human body, blood coagulation.
It really is. I mean, it's the process that saves your life when you get a cut, but it can also be the thing that ends it with a misplaced clot.
Exactly. So our mission for this deep dive is to get a really solid handle on the pharmacology that controls this whole system. We need to know when to form a plug and when to dissolve a potential catastrophe.
That's the plan. We're going to map out the entire clotting timeline from, that initial injury all the way to resolution. Then we'll break down the four big drug classes that manipulate it.
So that's antiplatelets, anticoagulants, thrombolytics, and the antihemorrhagics.
Right. We'll hit the mechanisms, the goals, and I think most importantly, the safety points you absolutely cannot forget.
And the context here is just so critical. You have to remember the cardiovascular system is a closed loop. Any leak needs an immediate seal. That's coagulation.
But that seal, that plug, if it hangs around too long, it becomes a thrombus. It can shut the whole system down. So the body also needs a cleanup crew, fibrinolysis, to take it apart.
And when that balance gets thrown off, too much clotting or too much bleeding, that's when pharmacology has to step in.
Okay, so let's unpack the biology first.
Yeah.
To understand the drugs, you have to know the sequence. What are the body's first moves when a vessel gets injured?
It's remarkably fast. The very first thing is just a brief local vasoconstriction.
The vessel just clamps down on its own to try and stop the bleeding. If that's not enough, we get phase two.
Platelet aggregation.
Right. The platelets get sticky, they adhere to the injury site, and they start releasing these chemical messengers, ADP, serotonin, thromboxane A2.
It's like they're sending out a distress signal, a siren calling for more platelets to come and pile on, right?
Exactly. They form that initial temporary platelet plug, but if the injury is bigger, the body needs something stronger.
And that's when the full clotting cascade kicks in.
It is. And what's so fascinating is that it activates two pathways at the same time, just to be sure. You have the intrinsic pathway.
Which is for damage inside the vessel. It starts with something called the Hagman factor when blood hits exposed collagen.
Correct. And then for blood that's leaked outside the vessel into the tissues, you have the extrinsic pathway, which is a bit faster. It's kicked off by tissue thromboplastin from those damaged cells.
So it's a double defense system. It's working from the inside and the outside.
And the key player, the one you really need to remember, is that Hagman factor, factor 3. It is the absolute linchpin.
Why is it so important?
Because it triggers three systems at once. It starts the clotting process, yes, but it also starts the clot dissolving process and the inflammatory response.
Wow. So it's managing the crisis and planning the cleanup at the exact same time.
Incredible, isn't it? So whether we started with the intrinsic or extrinsic path, they both lead to one final common step.
The conversion of prothrombin into thrombin.
And thrombin is the real workhorse. It's the enzyme that chops up fibrinogen and turns it into these insoluble fibrin threads.
That's the actual clot, the strong, stable mesh that really seals the deal.
That's the plug. But, like we said, it can't stay there forever. So what about the cleanup crew? The body's natural unclotting system.
Clot resolution.
This is the plasminogen system.
Hmm.
Plasminogen gets converted into plasmin, which you might also hear called fibrinolysin.
And plasmin is basically a protein-dissolving enzyme that just goes in and chews up those fibrin threads.
That's its only job.
Yeah.
And that natural mechanism is exactly what our clotbuster drugs are designed to exploit.
Okay, perfect. We have the sequence. Now let's start messing with it. First up, antiplatelet agents.
These are all about prevention. They're stopping that initial phase 2 plug from ever forming.
So these are critical for patients with thromboembolic disorders. You're trying to prevent an MI or a stroke or maybe keep a new graft open.
And their main action is just blocking receptor sites on the platelets so they can't get that sticky signal. Although there's one with a really unique mechanism, anagrelide.
What does that one do?
It goes right to the source. It actually blocks the production of platelets in the bone marrow.
And then there's the prototype everyone knows, aspirin.
Right. Aspirin's job is to inhibit the synthesis of thromboxane A2, that chemical siren we mentioned. We see it all the time for reducing stroke risk or for MI prophylaxis.
But not all of these work the same for everyone, and this is where we hit a really important safety point, specifically with clopidogrel.
Plavix, yeah. This is a huge clinical warning.
So what's the issue?
Clopidogrel is a prodrug. It has to be activated by a liver enzyme, CYP2C19, to work. The problem is some people are poor metabolizers of that enzyme.
Meaning the drug just doesn't get turned on.
Exactly. You think you've protected your patient from a clot, but they're completely defenseless. It's why the FDA put a black box warning on it.
So for those patients, you need genetic testing or you just have to switch to a different drug entirely.
Absolutely. It really highlights how personalized this therapy needs to be.
Okay, moving from the plug to the cascade itself, let's talk about anticoagulants.
Right. If antiplatelets stop the initial pileup, anticoagulants interfere with the deeper clotting factors and thrombin formation.
And we've got three main groups here: warfarin, heparin, and then the newer oral ones.
Let's compare the big two first. Warfarin, or Coumadin, is an oral drug. It works by stopping the liver from producing vitamin K-dependent clotting factors.
And the key thing to remember with warfarin is the delay, right?
A huge delay. It takes about 3 days to really kick in because it has to wait for the body to use up the clotting factors that are already circulating, and its effects can last for 4 or 5 days.
So given that delay, why would we ever use it when we have heparin, which is immediate?
That's the million-dollar question. Heparin is parenteral IV or subcutaneous, and it works right away by blocking the formation of thrombin. It's the go-to for acute emergencies. A DVT, a PE, you use heparin.
So warfarin is more for long-term?
Exactly.
Yeah.
Long-term prophylaxis. Think atrial fibrillation or a patient with a mechanical heart valve. That's where warfarin, despite being tricky to manage, really shines.
And that tricky management involves a lot of monitoring.
Constant monitoring. For warfarin, you're watching the PT and INR trying to stay in this very narrow therapeutic window. For heparin, you're watching the WBCT or the ABTT.
Which brings us to the third group, the NOACs, or newer oral anticoagulants. They seem to offer a way around all that testing.
They do. These are the direct inhibitors. You have dabigatran, which is a direct thrombin inhibitor, and then rivaroxaban, apixaban, edoxaban. They're all factors inhibitors.
And the big advantage is you generally don't need that constant blood work.
It's a massive win for patient compliance, for sure. But that convenience, it comes with its own set of very serious warnings.
What are those?
They all have a black box warning about the risk of rebound thromboembolic events if you stop them suddenly.
So if a patient just decides to stop taking their pill?
They put themselves at an extremely high risk for a stroke or a heart attack. It's critical they understand that. They also carry a warning about the risk of spinal or epidural hematoma if they get a spinal tap or an epidural.
Which could lead to permanent paralysis.
Permanent. It's a devastating complication.
And if there's an overdose, we need antidotes. What do we have?
For heparin, it's straightforward. We use potamine sulfate. It binds to heparin and neutralizes it instantly.
And for warfarin?
It's more complicated. Vitamin K is the standard antidote, but remember that delay? It takes 24 hours or more to work. If a patient is actively bleeding, you don't have that time.
So what's the emergency fix?
Prothrombin complex concentrate. You're basically infusing the clotting factors the patient is missing. It works immediately.
Before we leave this category, we have to touch on the ultimate clinical paradox, DIC, disseminated intravascular coagulation.
Ah, yes. This is one of the most terrifying conditions.
Yeah.
The body is clotting everywhere, using up all its clotting factors, and so the patient is also simultaneously bleeding to death.
Clotting too much and bleeding too much at the same time.
It's a vicious cycle. And paradoxically, the treatment is often low-dose heparin.
You give an anticoagulant to a patient who's hemorrhaging?
You do. The goal is to interrupt that out-of-control clotting phase just enough to stop the body from consuming all its resources, which can then, hopefully, stop the bleeding. It's a true test of your understanding of the pathophysiology.
That is incredibly complex. Okay, now for the big guns. The clot has already formed. We need to get rid of it.
Yeah.
Thrombolytic agents.
Clot busters. These are for acute emergencies. An MI, a pulmonary embolism, an ischemic stroke. We have to dissolve that clot to save tissue.
And the mechanism is just cranking up the body's own cleanup crew.
That's it. We're forcing the conversion of plasminogen to plasmin. Your prototypes are alteplase, retiplase, tenecteplase.
And with these drugs, the single most critical factor is time, isn't it?
Time is everything. For a heart attack, you have a window of maybe 6 hours from when symptoms start. Any later, and the damage is done.
And the risk is that they'll dissolve any clot, not just the bad one.
Precisely. Which is why the list of contraindications is so important. You can't give these to anyone with a recent stroke, recent surgery, active bleeding, or severe uncontrolled hypertension. The risk is just too high.
Okay, we've covered slowing and dissolving. Let's flip the script. What about patients who need help clotting? The hemorrhagic disorders.
Right, like patients with hemophilia who are missing a genetic clotting factor. For them, we use antihemophilic agents.
Which are basically just replacement factors.
Exactly. You're giving them the factor 8 or factor 9X that their body can't make. It's IV only. The main safety concern is the risk that comes with any blood product allergic reactions or, historically, disease transmission.
And what if the problem isn't a missing factor, but that the body is just breaking down clots too fast?
That's a condition called hyperfibrinolysis, and for that we use hemostatic agents. The systemic prototype is aminocaproic acid.
How does it work?
It inhibits the substances that activate plasminogen, so it stops that cleanup crew from working too aggressively. The main adverse effect to watch for is, you guessed it, excessive clotting.
And we also have topical agents for local use, like in surgery.
Yes, things like absorbable gelatin or human fibrin sealant.
Perfect. So let's bring all of this home. Let's synthesize the crucial nursing considerations that apply across all these drug classes. What are the non-negotiable lifestyle changes?
You have to frame it as a total safety shift. Patients need to use an electric razor, not a blade, a soft bristled toothbrush, and absolutely no contact sports
They also need to wear a medical alert notification.
at all times. That is non-negotiable.
And what's the universal monitoring rule? What do they need to report?
They have to report any sign of bleeding immediately. That means petechiae, those little pinpoint hemorrhages, bleeding gums, easy or excessive bruising, dark or tarry stools, or dark-colored urine.
The risk of drug interactions, especially with warfarin, is just massive.
It's legendary. Patients must report every single over-the-counter drug, supplement, or herbal therapy they're taking. We know that things like angelica, feverfew, garlic, ginkgo, even green leaf tea can dramatically increase bleeding risk.
What about the very young and the very old?
For children, it's very challenging. Doses have to be calculated meticulously by weight, and the safety of many newer drugs isn't well established. For older adults, they are the highest risk group.
Because of polypharmacy and potential organ impairment?
Right. Their liver and kidney function might be reduced, so the drug hangs around longer. You have to start low and go slow. Always initiate therapy at the lowest possible dose.
And the one key thing to do for any patient on these meds.
Mark their chart prominently. You need to alert every single person on the healthcare team that this patient has an increased risk for hemorrhage.
So we've navigated the three main goals: slowing coagulation, dissolving existing clots, and promoting clotting. It's an incredibly delicate, high-stakes balance.
It is. And what's still so fascinating to me is the sheer number of things that can throw that balance off. Diet, other illnesses, and especially other medications. It makes maintaining a stable, effective dose a perpetual clinical challenge.
Well, considering that volatility and the serious consequences of getting it wrong, how might something like genetic marker testing, which has been looked at for warfarin sensitivity, change things in the future?
Oh, it could be a complete game changer.
If we could know, before the first dose, exactly how a patient is going to metabolize a drug, that kind of personalized medicine could truly revolutionize the safety of anticoagulation therapy. That's definitely something to keep an eye on. Thanks for joining us for the deep dive.